Hello, I'm Llewellyn King, a co-founder with Deborah Woroff of this program on MECFS, the Alert. And I'm talking today with a very important man in the research and the development of a public position on this ghastly disease that has affected so many people, more than 1 million in this country and maybe as many as 17 million around the world. My guest is Dr. Lenny Jason. It was Lenny Jason who, looking at the numbers, doing the research, said, wait a minute, there are a lot more people than our government, the US government, through the Center for Disease Control in Atlanta, or the Centers for Disease Control in Atlanta, said there were. They were saying there was about 20,000. Lenny Jason, a doctor of psychiatry at DePaul University in Chicago, did the research and persuaded the CDC that there were at least 800,000 victims of chronic fatigue syndrome. Incidentally, it was the CDC which gave the name chronic fatigue syndrome, which has been so unfortunate and is so misleading, rather than the old name of myalgic encephalomyelitis. Welcome to the broadcast.
Thank you.
How did you get into this?
Began studying this from a personal experience of getting mono in 1989 and not recovering. It took me about a year and a half before I was able to come back to DePaul University, first on a limited basis. And when I did come back and finally got enough strength to start thinking about doing research in this area, I decided that prevalence and epidemiology was the most important thing to look at the early 1990s. And the reason for that was because if you have an illness that's considered rare, particularly an illness that's called a yuppie disease, which it was, then it's not going to be taken seriously. So even though I wasn't an epidemiologist, I realized that as a community psychologist, I could put a research team together to try to really find out what the accurate numbers were.
Now, tell me something about DePaul quickly.
DePaul University has about 25,000 students. It's the largest Catholic university in the United States.
And it specializes in?
It really has a mission for service. We teach, we try to do public service, just like St. Vincent de Paul did in France several hundred years ago.
Coming back to the problem of how many patients, if it is calculated there are too many, and CDC has now said as many as 4 million, that makes it very difficult to establish biological markers, right?
We've suggested that there's probably 800,000 to 1 million people with this illness. The CDC, over a 10-year period of time, changed their estimates from about 20,000 to over 4.5 million. We believe the only way that that type increase could have occurred, because we've been studying people during that 10-year period, and we haven't seen those types of increases in our natural history studies that we do. We've concluded that it's possible that the case definition has been broadened. And the reason we're concerned about that is if you look at depression, people who have major depressive disorder, that's one of the most common psychiatric symptoms and diagnoses. If you have about 2.5% of the population that has major depressive disorder and about 2.5% of the population that is now thought of as having CFS, you begin to wonder, is it possible that some people with this chronic fatigue syndrome label possibly have been brought in people with major depressive disorder to get the numbers up to 4.5 million.
And this is quite serious.
It's serious because if you misidentify people and you bring folks in who have another illness, then you possibly will have much more difficulties finding biological markers for this illness.
You've become a famous figure for your work, and you get a lot of telephone calls. Tell us about those and how heartrending they can be.
There are literally hundreds and potentially thousands of people who are locked out of the healthcare system. If you have cancer, if you have heart disease, if you have AIDS, there are treatment centers you can go to have diagnostics and a treatment plan put together. If you have this illness, you are, in a sense, locked out of the healthcare system, unfortunately, because you can't go into a physician and have 3 or 4 minutes or 5 or 6 minutes and have an appropriate diagnosis and treatment plan with something as complicated as this.
Why do you think this has been a disease so shunned, if you will, by the medical profession?
It's complicated, it's difficult, basically it's not a simple illness, and to basically do appropriate treatments takes a lot of time, and our healthcare system has difficulties dealing with complicated health issues like chronic fatigue syndrome.
Around the globe, who is doing the best job with chronic fatigue syndrome?
Well, I'm particularly impressed with the Japanese. The Japanese have a model where they basically have taken some federal support, spread it around to some of the best and most famous scientists in Japan, and really stimulated research from a first and a second generation of people. And I think that type model has worked extremely well, has generated some fascinating research, and could be replicated in this country.
Here in the United States, what is needed now? What could we do now if we had the will?
If we had the will, we'd have a series of settings, tertiary settings, kind of places where you could go in and you could get a good workup, diagnostic workup, and you could have a treatment plan put together, and you could have training of physicians and healthcare workers and even researchers being part of that. And then those people, once they got their diagnosis, could have a connection with people from their local community. So what we need is a network of settings where people can get appropriate diagnosis, treatment planning, and training for other healthcare workers. We do not have that now.
There will be more of my conversation with Dr. Leonard Jason on a future episode of CFS Alert. This is Llewellyn King in Washington. Hello, I'm Llewellyn King. I'm one of the founders and hosts of CFS Alert, along with Deborah Woroff in New York. I'm speaking to you from Washington, D.C., and I'm continuing a conversation with Dr. Leonard Jason of DePaul University in Chicago. Leonard, you've mentioned to me in other conversations, the last episode of this program actually, that you were quite impressed with what the Japanese are doing. That leads me to this question. Some diseases have been treated quite differently in Asia with good results. I mean, we think of acupuncture and things like that. Are there Asian treatments for ME/CFS that we have not tried in this country?
We really don't know in terms of empirically validated kind of efforts. We recently did a review of non-pharmacological alternative medicine treatments that was published in a journal this year. And we found that 2 of the most promising ones had to do with Qigong and meditation. Certainly right now, I would say that there's a need for good, rigorous research to find out what works.
I know what meditation is. What's Qigong?
It's a different way of kind of moving one's body in accordance with some ancient principles that allow one to do energy conservation.
And do you feel that have you tried any of this yourself?
Yes, I have.
With good results? Or?
You know, I think that I have a belief in a thing called the energy envelope, that if one can stay within sort of about one energy that one has and not exceeding it, that one ultimately can build up that energy battery, that stamina, that kind of, that battery that has sort of in some ways been very much diminished in many people with this illness. So anything that I think that is restorative, that allows one to pace, that allows one to monitor and sense one's energy level and stay in tune with that, I think can be very helpful with this illness.
In a previous interview, you said you were impressed with the way the Japanese were approaching the disease. What do you mean by that?
They have basically looked at all different aspects of the illness, from kind of physiological to what's going on in the brain, to what's going on in the neuroendocrine system, to what's going on in the immune system. That's not to say that we don't have some excellent researchers in this country. People like Ben Nadelson has been doing some fascinating research helping us differentiate Lyme disease from CFS illness.
Have you found any indication that there are different populations are differently affected? Is there an ethnic dimension to this?
We have found that rather than the yuppie illness, flu, that sometimes had been called in the 1990s, that individuals who have higher incomes are not more likely to have this illness. Actually, people from lower socioeconomic status, people in more poverty, are more likely to have the illness. We've also found that minority groups actually have more of this illness than people who are non-minority, Caucasian whites. Now, the reason that we don't understand this is because, you know, the people who go to the tertiary care centers and knock on the doors and try to get a diagnosis tend to have more resources, tend more to be white, tend more to be counted in studies. But when you do community-based studies, when you take the physicians and the medical personnel out of the case ascertainment method, you actually find differential rates of illness where minorities and the poor are overcounted and actually have higher prevalence than individuals who don't have this.
What would you like in the communities? What would you like to see done? You've done a lot of work with drug addiction, for example, where there are community solutions or post-addiction solutions. Are there community solutions for the sick people? Does it help people with CFS to know other people with CFS?
I think the two things that are most critical is one is legitimization of this illness. It's still not legitimized in many people's minds, whether they're healthcare professionals, even some family members, school officials. So how does one, in a sense, possibly think about changing the name, as you've said, from chronic fatigue syndrome to something more medically sounded like myalgic encephalomyelitis, which has been used in Great Britain and other European countries for many years. And the second issue is when people are very sick and have legitimization of this illness, then do we have a healthcare system that allows us to uniquely deal with their needs? And this is a very sick, this is a very impaired group of individuals. They need the best of medical care, multidisciplinary treatments, not the kind of treatments that's shunned off to one professional, particularly psychiatry or psychology. By treating everybody with this illness with one particular type of treatment modality doesn't work. But it wouldn't work with any type of chronic health condition, so why would it work with this one?
You are a psychologist rather than a medical doctor, which gives you a different perspective. And yet in Britain, the patients are very angry. In fact, there's been a tremendous fuss there over the attitude of the National Health Service that this is totally a psychosomatic disease. How do you answer your fellows in the field of mental health who've taken this attitude?
Well, I think that if we had patients with cancer or patients who have HIV infection and possibly AIDS, and patients who have heart disease, and they were brought to a professional, and the professional basically tried to argue with them that their illness was psychogenically caused and was psychological, the patient community would be in an uproar. And I think that's not the way to start a therapeutic relationship with patients. I think to legitimize the patient's concerns, to legitimize the patient's understanding of the etiology of their illness, to legitimize the patient's understanding of what they got is really the starting point of medicine. And I think that unless we get back to doing good medicine, where we basically respect and have patients in a respectful alliance with each other, with the therapists, with the medical doctor, with the healthcare team, and the patient, that's the way you start a respectful dialogue. That's what medicine is based on. If that doesn't occur, then you have significant problems. And I think that has happened in many places in Europe.
Do you think we've reached a point yet where there can be a published diagnosis so that physicians, general practitioners in particular, who treat this very poorly, can identify it earlier on?
I think that the 6-month period of waiting is a problem. Maybe for research purposes, I think it helps to have a period of time. But certainly, if a person has to wait that long to actually get appropriate treatment, you might have lost the best ideal time to actually intervene. Getting there early, treating appropriately with good comprehensive treatment might be the best way of helping individuals not get so sick and so impaired that their immune system is damaged where it's hard to have a full type recovery. So I guess what I'm suggesting is that, yes, the case definition is critical. Any type of science starts with trying to differentiate who has an illness, who doesn't have an illness. And if you can't do that diagnostic system reliably, then it's like a house of cards. That bottom level has to be solid because everything else is built on it. Epidemiology, treatment, etiology is based on trying to decide who has an illness, who doesn't. So that case definition, that diagnostic enterprise, is the most critical enterprise that any scientist or clinician can be involved in. And we still have more work that needs to be done in this area.
We will get back to the subject in a future episode, but for now, can you extend any hope to people who are felled by chronic fatigue syndrome and who suffer year after year, decade after decade? Some of the correspondence I get is absolutely awful, the suffering that is reported to me.
Yes, there is a tremendous amount of suffering. I get phone calls from people who have had tremendous amount of education, high-powered jobs that are living in a car and that have been abandoned by their family and the healthcare system. I know that there's many people that so many things have been taken away from them. And I think there's nothing more important to have that sense of hope, that there is tomorrow, that there is a possibility that there will be a way of us understanding this illness. I basically believe that an optimistic view is critical, and anybody who deals with patients or deals with the community on this level needs to sort of believe that, in a sense, we can make a difference. Because if we really believed that we couldn't make a difference, then think about all the other types of major illnesses and what would have happened if people didn't get behind some efforts to make a change. And HIV, AIDS community is a perfect example.
We'll talk in the future about other aspects of chronic fatigue syndrome, where there is hope, where there is promise, and what needs to be done now. I love a story that is ascribed to Winston Churchill. I don't know if it's true. I haven't been able to establish that he actually said this, but I can easily believe that he did. And that is when he was a very old man. He summoned his gardener and he said, "I want to plant an oak tree here." And the gardener, looking at how decrepit he was, said, "Well, sir, you know, it would take 100 years to grow." And Churchill allegedly said, "Well, you had better plant it now." So be it with CFS. Good day, I'm Llewellyn King, host of CFS Alert, along with my co-host in New York, Deborah Woroff. Together we have put together these programs on YouTube with the object of helping the sufferers, pushing the medical profession, and shaking up government attitudes. And no one has shaken the government up better than Dr. Leonard Jason of DePaul University in Chicago. It was Dr. Jason who said, basically, to the government, to the CDC in Atlanta, there are more sick people than you are counting. And suddenly that count, under pressure and data from Leonard Jason, went from around 20,000 to 1 million, and now they're counting possibly too many, possibly 4 million. Welcome to the broadcast.
Thank you.
That's a stunning achievement, as much as anybody has probably done in changing the attitude of people to the number of sufferers. I mean, giving essentially some recognition to society, to the politicians, how big a problem this is. Do you have any idea what it costs the country to have 1 million people who cannot work?
We have done some economic studies, and our estimate is probably about $20 billion a year.
You are a sufferer and functioning pretty energetically, if I might say so. And we're all glad of that. Is it a fact that men tend to be able to perform better when they have CFS than women? Or is that purely a misinterpretation of known cases?
Well, it's very interesting that the sympathetic system is probably different in males versus females. That's probably one of the reasons that the immune systems are different. If you look at a number of autoimmune diseases like lupus and MS, even fibromyalgia, they tend to be more females. So there's probably biological reasons for this male versus female difference in prevalence. In terms of recovery, or in terms of coping, or in terms of improvements over time, I would say you really need to look at the individual. Some individuals might not have been impaired as much initially. Some people might have had more supports to allow them to kind of begin to heal and cope. Some people might have had less pressures on them. Certainly there's lots of different conditions to help us understand why one individual seems to be improving while another person isn't.
I'm not a doctor, obviously. I'm a journalist, and looking the way journalists do at what we can see, which is often not enough, it seems to me that this may be a contagious disease because you have clusters, and there's a long history of identifying the clusters, going back actually I think into the 18th century, but more recently 1955 in England, and then 1985, a very seminal year, with two big outbreaks in the US, one in Nevada and one in New York State. How contagious is it?
It's a really important question you're asking, and many people have been wondering about that. Certainly there have been the best evidence is when we kind of see people who gets like a monotype illness and we follow them up in controlled circumstances. We find that something like 6 to 10% of people seem to have difficulties recovering after 6 months. After a year, it goes down to 2 or 3%. So yes, there are some people who get a mono or cytomegalovirus, which can cause mono, Epstein-Barr virus, who don't recover. So clearly, it seems like the illness can be precipitated by some type of viral insult. Now, Martin Lerner and several other people are going to be presenting some papers at some upcoming conferences that are actually going to suggest that it's actually more complicated, that it might not be the full Epstein-Barr virus, it might be particles, certain proteins within it that are not resolving, that might be implicated in what's going on with disease pathology. So this is a very complicated issue. We need the best of science. We need the best minds. We need a multidisciplinary effort to come close to understanding the nature of this problem.
The direct question here is, if your spouse or a child, or if you are a parent with a child, how much should you be concerned about contagion, about spreading it?
I would say that if you are genetically predisposed to get this illness, just like some people are genetically predisposed to get heart disease and cancer, and you have certain types of precipitating events, that there might be a likelihood that a person would develop the illness. But I think it's a complicated set of issues of exposure, of genetics, of predisposition, that help us understand who gets the illness versus who doesn't.
In one of the most famous outbreaks in Nevada and Lake Tahoe at Incline Village, there were 300 people, many of them children. Likewise in Lyndonville up in New York, about the same number. Could they all have that same predisposition? That seems improbable to me.
Well, it's a genetic predisposition, but there's also environmental events that are going on too.
Two very different environments. One rich, sunny, one cold, poor.
Well, it's very interesting that there was also one in Raleigh, North Carolina at the same time that was reported. And what was unique to those three kind of outbreaks is that, for example, in the high school, there was refinishing of the floor that brought out certain types of environmental chemicals that might have been implicated. And an orchestra in North Carolina, Raleigh, where a lot of the orchestra members got sick with this illness, also had their floors being refinished at the time. So in terms of what's really going on, there could be a variety of different issues involving the environment, exposure, in terms of genetic vulnerability, and possibly other events too. So all we're saying is that it's probably a variety of factors that could be causing these individuals to get sick.
I've heard from a lot of people who have the disease, in some cases where the partner is also infected with enormous fear for their children. And in one case, I think the child had become infected, if that's the correct description. This is a very serious situation. On top of being very sick, unable to cope, there now is the worry that you're essentially lethal to your nearest and dearest. Is there any reassurance that medicine can give at this point? Would you suggest that families break up, or that they have some special precautions of non-exchange maybe of bodily fluids or of cleaning surfaces, the normal things we do when a contagious disease is around?
You know, we have looked at family histories of people who have this illness, and we do find differences. And endocrine diseases seem to be more common in patients' histories with their family members.
What do you mean by endocrine?
Things like diabetes and things like that. We see more evidence of that. So I guess the question is, do I think families should break up? Absolutely no. Do I think families should be concerned about their children? Absolutely yes. The same factors that might have gotten a person ill, exposure to certain types of viruses or bacteria or other types of environmental contaminants, could affect their children. So yes, I think the family who's concerned, probably the best hope right now is to sort of say, hopefully we can get researchers to tackle this problem. It's a very complicated one. We need more research to help us understand who gets sick, who doesn't, and what are the reasons for it, and what are the different trajectories for trying to get better.
Finally, if you had a magic wand and could wave it, what would you have done tomorrow? What would you say to the government, to the medical profession, and maybe to the community itself?
You know, I think that the community needs to be educated to the seriousness.
Do you think the community is too angry and wasting what energy it has on anger?
I think the fact that you have many patients who feel that they've been delegitimized and feel that they don't have access to health care and feel that there's many people out there that are not helping them in their efforts to cope with this illness would suggest that they're upset, they're angry. And I think it's particularly legitimizing for them to have those feelings validated. There's nothing wrong with being upset if you feel like you haven't been treated properly. So I think that's fine. I think it's the larger community that we need to try to get on board. They need to understand that just like with the handicapping community, there was one time when basically people who were in wheelchairs, couldn't get out and could get mobile. And then we sort of said the society has to change. We have to give these people a chance to become mobile. We have to change the way environments are so they can get the wheelchairs in, and we have to change the attitude toward people with disabilities. The same issue is with people with this illness.
Back to the magic wand. I interrupted you and got you a little off track. What would you like to see? How much research should the government be doing? How should it be directed? Why isn't it happening?
This is really calls for a Manhattan-type project, very tough in these economic times. But if we can basically figure out what's going on with these types of unexplained illnesses, we will get insights into the type of medicine that will be directed for the next 50 years. Because broken arms, kind of influenzas, and these types of diseases and illnesses are things that we pretty much have a good understanding of. The challenge for medicine is these unexplained illnesses. And this is where we're going to have the richest dividends if we could put resources in trying to understand what costs society a tremendous amount of resources every year.
The few resources, the few therapies that there are any of them showing much promise? There's Ampligen, there's an ozone treatment, there's some some other treatments for any autoimmune disease. Any of them showing any promise? Any reason that people in bed today can be hopeful?
I think there's lots of reasons to be hopeful. I think we need to have controlled trials. So there's anecdotal kind of information suggesting certain people are doing better on one thing versus another. Martin Lerner has basically been using some antivirals and getting some very interesting results. But clearly, I think what we need is controlled trials with long-term follow-ups to be able to identify what really works.
That is our program for today, and I think the largest reason for hope is that there are people like Dr. Leonard, Jason, working in the field. We'll see you soon. Cheers.